Good afternoon. It's a pleasure to be here. I want to thank the organizers of what I'm sure will be a very important and interesting symposium for inviting me. So let me share my screen and get started with today's talk. So today I'm going to give you an overview of new drug development and take a historical perspective. I'm going to talk about where we started, where we got stuck, and where we're going. As far as disclosures, I now am an employee of Sanofi based in Cambridge, Mass, but I will not be discussing any of Sanofi's products. I do want to give a special thank you to my colleagues, Richard Gorlick, Katie Janeway, and Doug Hawkins, for sharing their knowledge, their perspectives, and importantly, many of their PowerPoint files. I do want to emphasize, however, that all errors in this talk are mine alone. New drug development, I'm going to talk briefly about novel cytotoxics and then talk a little bit in more detail about targeted therapy. And I've broken targeted therapy down into two broad buckets. One, molecular oncology, focusing primarily on small molecules, and then more broadly on immuno-oncology. So let me start with novel cytotoxics. And for that, I'm going to give a very brief history of methotrexate, adriamycin, and platinum, MAP chemotherapy. Chemotherapy and surgery continue to be the cornerstone of treatment for children, adolescents, and adults with osteosarcoma. And understanding how we arrived at MAP chemotherapy, I think, begins to help understand some of the challenges we have. So we have to go back to 1967, and Isaac Gerasi, who was at my former institution, Children's Hospital of Philadelphia, began treating children with acute lymphoblastic leukemia with high-dose methotrexate. And shown on the right here are some of the doses he used. They range from 500 milligram per meter squared up to 1500 milligram per meter squared. But to put it in perspective, and again, this is 1967, standard dose of methotrexate back then was 2.5 or 5 milligrams. So going to doses of 1 gram with leucovorin rescue was quite a leap and really was based on a good deal of preclinical research, as well as understanding the pharmacology of methotrexate. Forward to Norm Jaffe, looking at the data, and then in 1972, reporting on 10 patients he treated with high-dose methotrexate and osteosarcoma, and reported both partial responses and complete responses to high-dose methotrexate with leucovorin rescue. And that really set the stage for multi-drug chemotherapy. And by the 1980s, multi-drug chemotherapy was beginning to establish itself in the treatment of patients with osteosarcoma, but it became controversial. And the controversy was not everyone was convinced that chemotherapy was responsible for the observed improvements in outcome. And thus, Michael Link, working with investigators, including Teresa Vietti, the former chair of the original Pediatric Oncology Group, or POG, set out to do a randomized trial. And that randomized trial was going to ask, is chemotherapy truly important for taking care of patients with osteosarcoma? And the results were rather conclusive. Now, shown on the right are the survival curves, with the upper curves being patients who were treated with adjuvant chemotherapy. And there were two groups of patients because it was becoming clear in the eyes of many investigators that chemotherapy was important, and not everyone was willing to be randomized. So the study looked at both randomized patients, and those are the curves with fewer patients, as well as those patients that selected to be on chemotherapy, and those are the curves with more patients. Nonetheless, it clearly demonstrated a significant advantage to adjuvant chemotherapy, and by 1986 established that adjuvant chemotherapy was an important component of treatment for patients with osteosarcoma. Well, this curve is also important because it really shows what our challenge has been. So if one looks at this curve from a paper in 1986 from Michael Link and compares it to a curve from data 30 years later, you can see we haven't made progress. These curves are virtually overlappable. We are stuck at about 70% event-free survival for patients with localized osteosarcoma. So let's take a step back and talk about how we have made progress in the treatment of childhood cancer. And really, it's been the application of some generalizable treatment principles that have driven this. I want to share with you what I think are the 4 fundamental principles that have helped improve the outcome for children with cancer. The first is combination regimens. That is a concurrent administration of multiple non-cross-resistant anti-cancer drugs. That became the cornerstone, combination chemotherapy of cancer treatment, not only in children, but cancer treatment in adults with cancer. Dose intensity, administer the highest tolerable dose at the shortest tolerable interval. Now, this was most recently realized in a study in patients with Ewing sarcoma with interval compressed chemotherapy, another approach to dose-intensive chemotherapy. Adjuvant setting, administration of drug when disease burden is minimal, and risk-adapted treatment by using biologic and other risk factors, and perhaps most importantly, the response to initial therapy guiding further therapy. These treatment principles have driven the improvement in outcome for children with cancer. And this is probably best visualized when one looks at the history of children with acute lymphoblastic leukemia. So shown here is data from the Children's Cancer Group, Children's Oncology Group from the late 60s to most recently up to 2009. And beyond the quantum leap that occurred in the early 1970s with the advent of preventive CNS therapy for all children with ALL, every generation of trials has improved the outcome, and it's improved the outcome in large measure by applying these principles. However, the story for osteosarcoma is quite different. Even though these principles have been applied over the years, progress hasn't been realized. So when one looks at the US, really since the 1980s, there's been no progress, be it in children less than 15 years old or 15 to 19 years of age. We've seen no progress. This is not just a US phenomenon. Looking at the curve on the right from Mike Isaachov's paper, again, whichever cooperative group has looked, we always end up at the same place. We have not made advances by applying these principles. This was, I think, most clearly demonstrated in the largest trial in patients with osteosarcoma, and that was URAMUS-1, a collaborative study between Europe and America that looked at whether in addition to MAP chemotherapy, the addition of ifosfamide and etoposide in a subset of patients could improve the outcome. So it was a large randomized trial, and they applied these principles. The first principle was adapting therapy based on initial response. So for patients who were poor responders to initial 2 cycles of chemotherapy, they were randomized to receive either continued MAP chemotherapy or MAP chemotherapy with the addition of cycles of IE, VP16 ifosfamide, or IA, ifosfamide and adriamycin. Now recognize that VP16 and ifosfamide both had single agent activity and as a combination had upwards response rates of 40 to almost 50% in relapsed and refractory patients. So there was likely not a more effective regimen that was potentially non-cross resistant to MAP, and that's what went forward. Unfortunately, you're all familiar with the results, overlapping curves. This did not improve the outcome. It checked every box: combination regimens, dose intensity, adjuvant treatment, risk-adapted therapy. But unfortunately, URAMUS-1 is not an outlier. Even as we try to identify novel agents in the relapsed and refractory setting, the vast majority of our cytotoxic studies have not shown positive results. One can go from drugs like topotecan and oxaliplatin all the way up to most recently eribulin. We are not seeing signals of efficacy. So fast forward, I think we've all come to the conclusion that for novel cytotoxics, no meaningful likelihood of improving the outcome will emerge, and would have to be under rather exceptional circumstances that we would continue to develop new studies for such agents. So let's turn to targeted therapy, and I'm going to begin with molecular oncology. Well, step 1 in any targeted therapy, including in osteosarcoma, is identify the target. Now, for most childhood cancers, we have a different kind of problem. If one looks at the mutational landscape of cancer, and shown here are the somatic mutation frequencies by the different types of cancers, on the left side of this curve with very low mutation frequencies are many childhood cancers. On the right side of the curve, you have tumors like melanoma, lung squamous cell carcinoma, orders of magnitude higher. The outlier for us in pediatric oncology is osteosarcoma. So if one looks at a circus plot of a patient with osteosarcoma, the genome is remarkably disrupted. No other pediatric cancer has a genome as disrupted as osteosarcoma. What's driving this? Well, we learned about 10 years ago of something that's now called chromothripsis. This was a paper by Stevens and colleagues, massive genomic rearrangement acquired in a single catastrophic event during cancer development. So they uncovered this where there are tens to hundreds of genomic rearrangements that occur in a one-off cellular crisis. And when one looks across the spectrum of cancers, looking at the percentage of samples with chromothripsis, at the highest end, where the red arrow, the second highest is osteosarcoma. So this leads the way in disrupted genomes. What does that mean for identifying targets? Well, I think the simplest way of putting it is it means it's complicated. And the reason it's complicated is because there are so many different variations. However, progress is being made. So this is work that was driven in large measure by a parent advocate, Teresa Beach, working with a number of investigators in Foundation Medicine, and basically started to find small subsets of recurrent potential targets. And this has helped setting the stage now for clinical trials. And one of the largest clinical trials taking place to look for signals of targeted agents is the NCI Children's Oncology Group Pediatric Match Studies, where specific genomic testing is done looking for a portfolio of different potential targets. If the target is found, a drug can be administered in a phase 2 setting. So shown here in a study that's led by Will Parson and Nita Seibels are the 10 current arms that are enrolling, and patients with osteosarcoma are also participating in this study. This is not the only study that's occurring with targeted therapy. We're seeing an increasing number of targeted agents being interrogated to see if there's a signal. But perhaps one of the strongest signals that has emerged in these patients has been with multi-targeted kinase inhibitors. So in this case, these are agents that don't just hit one kinase, but actually hit a number of different kinases. And that's in fact what might be needed in a disease as heterogeneous as osteosarcoma. But we are seeing repetitive reports of reasonable partial response rates, and perhaps even more importantly, 4-month progression-free survival rates that are telling us there's a signal here that should be interrogated. So currently, the Children's Oncology Group is developing a study to look at MAP chemotherapy in combination with cabozantinib, one of the multi-targeted TKIs, to see if in fact, one, it can be successfully combined, and two, can we begin to see evidence of an improvement in outcome. So where I would say we are in molecular oncology is newer methodologies, newer genomic testing is beginning to be applied, and a number of leads are being identified and being pursued in the clinic. So let me now turn to immuno-oncology. And you would think by my listing it here as the last topic, it's the newest field of drug development. And in some respects that's true. In osteosarcoma, that actually is not true. So bear with me as I once again take you on a very brief history of immunotherapy for osteosarcoma. It begins with a surgeon, pictured here. This is William B. Coley, who was at the time called a bone surgeon, that would be called an orthopedic surgeon. And in 1893, he published this paper in the American Journal of Medical Sciences, entitled, the treatment of malignant neoplasms by repeated inoculations of a bacterial infection. And he reported 10 cases. He referenced an early paper, and I think it's interesting to read the case report from the publication he made in 1891. So now 130 years ago. The treatment has become known as Coley's toxin. Here's one of the cases. In the cases which I've collected, there's one which bears upon this question. The patient, a male, 35 years, was operated on by Dr. Bull in 1888 for a large periosteal round cell sarcoma of the lower third of the femur with secondary deposits in the center of the bone. Amputation of mid-thigh and upper thirds was performed. Second week after operation, the patient had a very severe attack of pyemia, multiple abscesses in various parts of the body, fever 104 to 105. Last paragraph, the patient has had no recurrence and is now living nearly 3 years after the operation. But Dr. Coley appropriately appeared cautious even back in the 1890s. Of course, this is not to be regarded as absolute evidence that the attack of pyemia had any influence in preventing a recurrence. But when we consider the highly malignant nature of the tumor and remember how few do not recur, there still remains a reasonable degree of probability that such influence existed. And he pursued the idea of generating a robust immune response through infection with high fevers by actually infecting patients with toxins that he knew would drive fever to treat patients with cancer, including predominantly patients with sarcoma. Now, this was met with a fair amount of skepticism over the years, but largely was then put on the back burner completely with the advent of radiotherapy and ultimately nitrogen mustard and other chemotherapeutic agents. And that's where immunotherapy remained up until, again, probably the 1960s when it comes to osteosarcoma. So this was a report of a vaccine trial by Ralph Markov and colleagues. Began in 1963, and they made a lyophilized homogeneous vaccine from the primary tumor tissue and was given to a child with osteosarcoma and pulmonary mets. And ultimately reported on that series, and the analysis they did suggested that there may be some benefit. Again, an uncontrolled single-arm study, but the idea of vaccinating against a tumor, developing immune response, was being pursued pretty actively in the 1960s. Now, what I would say a rather more dramatic approach to this was predominantly late 60s, 1970s, adoptive immunotherapy, a term that really we would not see again probably for another decade in the treatment of primary osteosarcoma. And I've highlighted it on the left. Fresh aliquots of osteosarcoma obtained at the time of surgical ablation were transplanted to a human recipient. Now, let me pause there. They don't detail exactly who this recipient was, but it was allogeneic. And actually, you can dig back in the literature, and it appears were predominantly transplanting the tissue into another patient with disseminated osteosarcoma. I think in the current era, many IRBs would probably collapse when they heard this, but this was done back in the late 60s and 70s. They would transplant tissue to a recipient. Reading on, after periods ranging from 14 to 21 days, the implants were excised and presumptively sarcoma sensitized peripheral blood mononuclear cells were obtained from the recipient by leukapheresis. These allogeneic cells were immediately infused into the implant donor. Adoptive immunotherapy, late 60s, early 70s. They reported on, I believe, a total of 32 patients. They could not find clear evidence of an anti-cancer effect in this series. Now, let's fast forward to some more recent signals for osteosarcoma immunotherapy and muramyl tripeptide, MTPPE, MEPACT, had its own controversy, but again, I don't think any of us would argue that there was clear signal that the immune system could be engaged. More recently, work done by Nikki Mason at UPenn with a HER2 targeting listeria, trying to induce HER2-specific immunity, this in a canine model, very intriguing data as well. So some clear signs that the immune system could potentially be engaged or can potentially be engaged to treat patients with osteosarcoma. Now, immunotherapy really took off in the last 15 years. And one of the major drivers of that was the development of checkpoint inhibitors. The paper, I think one of the most seminal papers, was that from Jim Allison's lab back in 1995, where he described CTLA-4 and demonstrated that inhibitory signals derived from CTLA-4 were an important way that cancers evaded the immune system. And he continued to build on this work. And ultimately, this hypothesis was tested in patients with melanoma with ipilimumab, a CTLA-4 antibody. And this paper, published in August of 2010 in the New England Journal of Medicine, clearly showed a significantly improved survival of patients treated with ipilimumab. They also co-administered it with GP100, which didn't seem to have an impact beyond ipilimumab, improved the outcome for patients with melanoma. And this launched a real tidal wave of clinical trials using checkpoint inhibitors. Jim Allison and Tasuku Honjo went on to receive the 28th Nobel Prize in Physiology or Medicine for their work in this field. And it truly has transformed not only how we think about cancer, but now today, how we treat cancer. So those of us in pediatric oncology, when these data emerged, most of us immediately started thinking about osteosarcoma, because what soon followed was the idea that it was a high burden of antigens and perhaps more importantly, neoantigens that would drive the response to checkpoint inhibitors. And where would you look for the most neoantigens? Well, you would look in a tumor that had a highly disrupted genome, and thus we thought osteosarcoma. If any tumor in pediatrics is going to be responsive, it ought to be osteosarcoma. Well, unfortunately, like before, it's complicated. So pembrolizumab, a PD-1 inhibitor, shown on the left, is a waterfall plot. And as you can see in this study, in the purple bars, 19 patients with osteosarcoma, only one patient with a response. Very, very limited activity, pembrolizumab. But it hasn't been only pembrolizumab. A number of PD-1 inhibitors and PD-L1 inhibitors have been studied. On the right, a swimmer's plot for nivolumab. And if you look at the second from bottom, the swimmer's plot in yellow, these are the patients with osteosarcoma, 13 patients. You can see very quickly, they stayed on therapy for a maximum of 2 cycles, and the majority came off before then. So highly disappointing that we could not leverage a major advance in cancer treatment for patients with osteosarcoma. But we, and many people who do research in this area, are learning more. And we're learning more, understanding what is driving the lack of responsiveness and potentially how to overcome that lack of responsiveness. So this paper by Dr. Wu at MD Anderson, Immunogenomic Landscape of Osteosarcoma, really uncovered some data, and they drew, I'd say, 5 major conclusions from their work. Mutation burdens are not associated with immune infiltrate levels. So it's obviously the T cells within the tumor that are going to drive that response, but they could not find that correlation. Surprisingly, a low level of predicted neoantigen expression. And if you look at the figure on the right, looking at the number of non-synonymous mutations, you can see the expressed neoantigens level in red are a very small minority of what one would have hoped was being expressed. They also went on to postulate and show data suggesting low T cell receptor productivity clonality, insufficient immune infiltrate, and ultimately evidence for multiple immunomodulatory mechanisms. This work and work by many other investigators are now giving us new clues and thinking about new approaches to immuno-oncology for patients with osteosarcoma. And many of us really view this as an exciting time because the armamentarium that we now have in immuno-oncology is continuing to grow and grow almost at a daily basis. It's not just monoclonal antibodies that are now available to us. An increasing number of antibody drug conjugates, antibodies against targets that may be quite relevant to subsets of patients with osteosarcoma are in the clinic. We see bispecific antibodies being developed for solid tumors, trispecific antibodies being developed, really remarkable chemistry that is undergoing to the development of very potent and very specific antibodies that can engage the immune systems in ways that we really couldn't have imagined 10 years ago. Layer on that, the advances in cellular therapies, not only CAR T and building T cells, but now NK cells are coming onto the horizon. So an increasing spectrum of approaches that will hopefully begin to unravel the recalcitrant nature of osteosarcoma. So despite Dr. Coley having introduced immunotherapy more than 130 years ago, I think it's best to think about immuno-oncology as we really are just getting started. We're at the beginning of this process. It can't come too soon, but advances indeed will come. And I think in targeted therapy, and specifically in immuno-oncology, we're going to see those advances come for subsets of patients with osteosarcoma over the next 5 years. So let me close with another person that was highly important to improving the treatment for children with cancer, and specifically to increasing the cure rate for many children with cancer, and that's Trudy Elian. And if you don't know, Dr. Elian, work that she began in the 1940s and continued through the 50s, 60s, and onward, her laboratory developed 6-mercaptopurine, 6-thioguanine, azathioprine, acyclovir, and even AZT used for the treatment of HIV. Truly a remarkable scientist who was developing therapy that today we would call targeted therapy. Back then, the term hadn't been invented, but she knew exactly what she wanted to go after in the cell and to develop molecules to go after that. And so when she gave the presidential address in 1985 to ACR, and 2 years later, I think, she and George Hitchens won the Nobel Prize in Medicine and Physiology. This is what she said in a talk that she entitled Selectivity, Key to Chemotherapy. For many years, chemotherapists have thought the touchstone, which would turn lead into gold, the magic bullet of Ehrlich, which would go directly to the target without harming normal cells. And she went on to say, once you find the basic biochemical differences between the target and the host, then seek ways to utilize this information. Those principles most certainly continue to apply today. They apply for targeted therapies, be it molecular oncology or immuno-oncology. So with that, I'm going to end my talk. My dogs, Roscoe and Luna, have been waiting patiently for me to stop talking to the computer, and I thank you for your attention.